I'm leading an ASCO education session this weekend on emerging cell therapies in head and neck cancer. I'll be discussing tumor-infiltrating lymphocyte or TILs, CAR Ts, and TCRs. All of them are very early stage in clinical development. However, they are exciting prospects for the future. TILs have been studied for ages, and there's recently an FDA approval for metastatic melanoma with lifileucel, and we're trying to apply that same logic to patients with head and neck squamous cell cancers. Now, to give you a little bit of background, patients with metastatic disease have a very poor overall survival outcome. They, on average, live about 11 to 13 months despite our best efforts. And we have one standard of care treatment, which is pembrolizumab, but that treatment only tends to work about 20% of the time. So 80% of the time, patients tend to have progression of their disease despite immune checkpoint inhibitor. TILs provide another way of activating T cells in order to try to improve upon response rates in patients with metastatic disease. The thought process is that although checkpoint inhibitors can allow T cells to interact with cancer and cause cancer regression, sometimes the tumor microenvironment makes it very difficult to do so. There are lots of inflammatory and immunosuppressive cytokines that are secreted by the microenvironment, which makes T cells maybe ineffective. And so what TILs allow us to do is we are able to take out these T cells, recharge them, and give them back to the patients in a way that will hopefully enact some changes. Yeah, so in the past, we've really focused on what we call bulk TIL, which is just taking lymphocytes from a patient's tumor and recharging them. The nice thing about that is that they're polyclonal. They have a heterogeneous antigen response. However, we don't know which T cells are really doing the work. And so the next stage is a couple of things. One is selective T cell enrichment, so focusing on figuring out which T cells are actually doing the work and recharging those specific T cells to improve upon bulk TIL. Another is adding interleukin support, and particularly membrane-bound interleukin can be helpful potentially. And then there's also new antigen-directed TILs, which is really focusing on cancer-specific T cells that can help overcome the problems that bulk TIL may have. The new technologies are really fantastic, at least in theory. They can increase logistics, the complexity of the logistics involved, and many times patients may not have time. And so really the goal is to try to reduce the vein-to-vein time from TIL harvest to actually giving patients these newer methodologies. CAR Ts are still very naive, or early in stage as well. CAR Ts are able to direct their targets towards surface antigens. Many solid tumors, including head and neck, tend to have heterogeneous antigen expression, so it becomes a little bit difficult to find one selective antigen to target. However, logic-gated CAR Ts may overcome that problem and allow for a widening of a therapeutic window that otherwise would be narrow.